So this will be my third and fourth lecture. So I'm going to share with you some experience in using the endoscope, in particular managing infective hydrocephalus and intraventricular hemorrhage in our hospital. By definition, intraventricular endoscopic lavage refer to a procedure where you use the endoscope to replace the contaminated or affected CSF in the ventricle with an artificial solution, either Ringer's lactate or Hartmann. So this can be done especially when you have an intraventricular hemorrhage. And in our case, we started with a problem. In 2008, we analyzed our own data to look at the shunt survival for 12 months. We found that our infection rate was very high at that particular time. It even reached up to 23%. And small portion of these cases, patient developed pyogenic ventriculitis. So this is one example of 6-month-old baby who presented with prematurity intraventricular hemorrhage and hydrocephalus. So VP shunt was done and subsequently infected with Staphylococcus aureus, and patient come in sepsis. You can see from these images, so there is a pus ascending along the shunt tract. And from the CT scan, you can see a sediment within the ventricle at the independent part, at the occipital horn. And when we do a contrast, you find that there is ependymal enhancement, and there is ventricular debris, and the presence of hydrocephalus and clinically patient in sepsis. So in our experience, the mortality from pyogenic ventriculitis can goes up to 50 to 70%, especially in terms of gram-negative organism. So in the previous year, we just put an EVD, so we thought we can't do that anymore. So it comes to an idea that we want to use scope to remove all this debris objectively under direct visualization of the scope. So we use infant feeding catheter, as you can see here. We cut straight, and this infant feeding catheter actually translucent with a blue tag, and we use our endoscope minop so that we can aspirate the content. So this is how we cut, and we connect this catheter into a suction, and the suction at the same time we use a triple way. So one of the most important thing is that we connect this infant feeding catheter to a sucker, so that the sucker you can control with your thumb. So at certain pressure, if you use too high, you may experience the ependyma as well, especially in infective process, it can be very friable. So what we do, we make a typical ventriculostomy and the ventricle. Now we use the infant feeding catheter, we aspirate the pus first. So you see that it's quite easy using this infant feeding catheter. Because you can know what is going inside your catheter, and then we go to the floor of the third ventricle, and you start to see the interthalamic mass. So once we have cleared the content, so we start the irrigation. Because if you start the irrigation too early, the pus will throw everywhere. Then you have a snowstorm. You don't want to do that because you will lose the ependymal target. Yeah. So this is how it looks like on second day after surgery, and then the child. In this case, the first experience we put temporary EVD, and then eventually we have to shunt the child, and this is about 6-month follow-up. So the child survived, and then the recovery was very good. So if you look at the literature, pyogenic ventriculitis is a rare complication of severe intracranial infection. It's a potentially life-threatening. The mortality can be very high. Therefore, early diagnosis and aggressive treatment is essential. So we have a case like this. Eventually, the child died. And because of the pus, we do craniotomy, take out sepsis, but never wake up after that. So in another case of pyogenic ventriculitis, so we use endoscopic lavage to clear it. Sometimes because of the infection in the ventricle, even though you have cleared it, because of the healing formation, so the ventricle can be very stiff. So you may have a slit ventricle syndrome after that. So in this case, you can see the ventricle are very small. And eventually we have to shunt the small slit ventricle, and the child recovered. So based on a few experience, so we decided to do as our quality improvement project. So look at within 3 years, we managed to do 8 cases of pyogenic ventriculitis with a follow-up in average about 18 months, and the youngest day 14, newborn, to the eldest is 12 years old, and then 12 months. If you look at the data, so majority are caused by Staphylococcus aureus, and we have gram-negative Salmonella, E. coli, Klebsiella, and Serratia. So we do lavage in all cases. There was no complication related to the procedure, and to our impression that all child was alive. So that was a very good outcome that we thought we have solved some problem that we have been hunted for many years before. So all cases we receive antibiotic about 6 weeks, and out of this only 4 require shunt, and then 4 do not require shunt at all. If you just put an EVD, you give antibiotic, systemic, intrathecal, all this infective material will not be able to come out spontaneously. In fact, it will heal inside and it form a lot of problem. They can have a sepsis, empyema, and then sometimes macular hydrocephalus. So a little bit of the description of the technique. This is an underwater technique. So we use gravity feed irrigation. We use a Hartmann solution and warm at the body temperature. And we hang on the drip sand. So we also use a 3-way. We connect to 20 cc syringe, and then we can positive push. When I ask the assistant to shrink out, then they will give some push so that I can see what is going on in front of my scope. So I use suction irrigation technique, sweeping, grasping wheel. I will show you shortly. So our first experience, we use a single borehole that we found that even though we do septum pellucidotomy or we through the foramen of Monroe, so we found that there is a pocket of pus which cannot be removed using a single technique. So therefore, we have to repeat again the lavage, and then subsequently we decided that the best is to do bilateral like that. So all pyogenic ventriculitis, you need to go bilateral because you have a very good control. You can clear the entire ventricle. So we have some algorithm. First, we clear the frontal horn. Then we go to the septum because septum is the least critical structure. In case you injured, less likely you have problem. Then we go to the lateral wall, which involve the thalamus. And then we go towards foramen of Monroe, clear to the coral plexus, and down to the occipital horn. Once you clear on one side of the ventricle, then only we go to the third ventricle. Then we fill up with Hartmann solution again. Then we open the opposite side and we repeat the same maneuver. So this is what I described as fish biting. So what I do, I use the suction infant feeding catheter. This infant feeding catheter is not rigid but not so flexible. So you can see that I can like simply bite the slough, and in fact, if you're careful enough, you can elevate the slough like a carpet. Yeah. So sometimes I use the tip of endoscope, but only for Minop, because Minop by Ascolab, the tip a bit rounded. It's quite safe. If you use Calstos, the tip a little bit sharp, you can cause injury to that parenchyma. So this is how I elevate the slough, the carpet of slough. And be careful as you work along this structure, especially when you go towards coral plexus. Post-infection, the coral plexus can easily bleed. So if you're not careful enough, you will cause hemorrhage. So once you cause hemorrhage, you got double problem. You got infection, you got IVH. So you have to be very careful. So this is how I elevate, I call it as a carpet of slough using the tip of the endoscope. So you can use grasping forceps. Okay, you can grab it and rotate. You can use all this combination. But the trick is first to find the nearest normal ependema as possible. Then you're moving towards the slough. If you go towards the slough straight away, you cannot estimate the depth of the thickness of the slough as compared to the ependema. So sometimes if the slough is very sticky, stick to the coral plexus, so I dare not to remove, because sometimes it can cause torrential bleeding, especially in acute inflammatory process. So that ependema can be very friable. So you can end up with more damage rather than good. Yeah. So we publish our part of our description in child nervous system, and we also trying to conduct a prospective analysis. This is still ongoing into collecting a data from 2017 to 2021. So we compare a group of patients with ventriculitis treated by endoscopic lavage versus those who just treated with EVD alone. And then these are preliminary outcome. The detail will be come out later. So we look at the mortality. Those who receive endoscopic lavage has a lower mortality, about 22% compared to conventional management, which is about 40% in this series. Initially was worse, about 70%, but now of course with the antibiotic, more meticulous, but yet, despite without lavage, the mortality remained high, about 40%. In terms of outcome, this is outcome at 3 months and 6 months, 66% survive well, and then they have some grading, and then whereas those conventional management, only 24% has a good outcome. So hospital stay definitely you can see shorter than those who just receive EVD. So based on this experience, so we found that early diagnosis and aggressive treatment is essential for pyogenic ventriculitis. Bilateral endoscopic transcranial intraventricular lavage is safe, even though initially we thought can be dangerous, especially in newborn. So it is effective even in infant. So it facilitates CSF clearance and prevent further neuronal damage. And it also proves in front of our eyes that those who receive this lavage, the baby recovered faster. So they can come out from ICU shorter than what we used to be before. So of course it improves outcome as well, but we will wait for the analysis to prove that based on our local experience. So after that, we expand our indication of this lavage, not only on infection, but also looking at improved shunt survival. So now we're looking at those who had a previous shunt and has a repeated suboptimal shunt functioning or repeated shunt malfunction blockage, for example. So what we do, if we analyze, we found that the high protein cell count is increased. We remove the shunt, we do lavage. And then if intraoperatively clear, then we straight away shunt. If not, we put temporary EVD and then we do analysis. Some we repeat the lavage. Sometimes straight away we can shunt within 5 days. And it's proven that all this undergone shunt lavage, the shunt survival is prolonged compared to before. Yeah, so this I will show you some cases how does it work. So we also use for recurrent shunt malfunction, recurrent shunt infection. We also expand in the prematurity intraventricular hemorrhage, and we also use this lavage for some post-excision intraventricular paraventricular lesion, some cases of post-clipping aneurysm with IVH in adult. So as you know that intraventricular hemorrhage, the clot within the ventricle will be organized after a few hours, and this can cause blockage to the CSF conduit, resulted in acute hydrocephalus and eventually cause raised intracranial pressure. So the prolonged presence of clot deep within the brain cause reduced consciousness level and increased mortality. And this blood gradation product can flow within the CSF and eventually cause fibrosis of the arachnoid granulation tissue, and patient later develop delayed communicating hydrocephalus. So it is quite wise that if you can remove the clot, so you can stop this cascade from happening, you can of course remove the clot and you can improve patient survival. So this is an example of day 5, a child. We had a post intraventricular hemorrhage. So the challenge that when you remove a clot, they are usually organized. There are a lot of studies that use fibrinolytic agent like urokinase to liquefy it. But at the same time, in the intraventricular hemorrhage, usually you have poor visibility, and then the ventricles sometimes collapse because of the clot filling up. Actually, even though there is hydrocephalus, but it mixed with clot as well as the large ventricle. So rehemorrhage can happen, especially those who are uncontrolled hypertension, and you need a special equipment. So this is example of 58-year-old gentleman, known case of hypertension for 8 years, but defaulted treatment for 2 years, and presented with sudden onset of right-sided body weakness, followed by reduced consciousness. The GCS on admission was 10. Pupil T3 BP was high. We managed to control the blood pressure. And you can see here she has a thalamic hemorrhage on the right side and biventricular IVH. So typically, usually we put an EVD. So in this particular case, we try endoscopic approach. So our target is actually try to clear the CSF, and then we try to remove the clot from the thalamic hemorrhage using contralateral approach. So this is where I use an endoscope mounted with navigation, so I can get my trajectory well. The site of insertion same, pre-coronal hole, so that same site that you can use for ETV. So I use LOTA, because LOTA has a larger diameter. If you use MINOP, the working channel is too small. So LOTA has a larger diameter. They can use a bigger suction, and you can use a bigger, a grasper. So this is the concept. What we do, we try to remove the clot first, and then we do septum pellucidotomy to get to the contralateral side. And then we go out, we go to the Monroe, and then we get into the thalamus. So this is just to show you again, sometimes we can use a single hole, but certain case we have to do bilateral. So for IVH, usually I make a slightly larger mini craniotomy, about 3 times 2.5 centimeter, and then I make a flap incision in case I could not reveal the clot properly. Then I can convert to standard microscopic procedure. So this is how it looks like as we enter the ventricle. So usually after a few hours, the clot will form like a capsule. So you have to break this pseudo capsule. Now I use infant feeding catheter. So again, I cut straight. So I try to break the pseudo capsule. So once you break this pseudo capsule, then you will find the clot, which is more liquefied inside. So then you can use this suction irrigation technique to take out the clot. Of course, there are ultrasonic QSA that used for endoscope. Can't remember the company name, but you can only use in a gap endoscope. That is very specific intraventricular QSA system, which is unfortunately available in our hospital, but we don't have gap, so we cannot use that. So now you start to see the Monroe, yeah, and then this is actually on the floor of the, sorry, this is we do septum pellucidotomy. And then you start to see the clot on the contralateral side. So we repeat a similar procedure, then eventually we take out the clot. And when you have intraventricular hemorrhage, sometimes even during the procedure, you just have to wait, because this blood, they tend to get together later, and eventually they form a blood cake. Blood cake means they will connect it to each other like a long, I call it dragon. So you try to hold the head of the dragon, and you can grab and you pull out together with the endoscope, so they will come in one piece. So you do this, you take a while, give about 5 minutes around that, then we start, they start to form a blood cake. Then you can take out the clot easily because they will come as a one clot. Yeah. So you can use if a feeding catheter, sometimes we use grasper to further clear up. So now you can see the difference between before lavage and after lavage. Again, so we publish our data looking at the shunt dependency in IVH treated by endoscopic washout versus extraventricular drain. So we use GRAP score, as you can see on the slide, and the outcome shunt dependence is significantly lower in patients with massive IVH who are treated with endoscopic washout. So duration of EVD weaning is significantly shorter in patients treated with endoscopic washout, and there is significant reduction of GRAP score in patients who underwent endoscopic washout, and no significant difference in terms of UVD infection in both groups. So this is a preliminary data that we get from our small series using this lavage in IVH. This is example of IVH and post-op. So we also use this for other cases. For example, this case with parietal meningocele with infected shunt, we do lavage and remove because the shunt is get blocked. So now you can see in the repeated shunt malfunction. So as you enter the endoscope, there are like an oily material. So this is how and why your shunt is get blocked intermittently. So you can also see that following IVH and infection, so the ventricle wall become very stiff. This is how you can develop street ventricle syndrome post-infection. So as you slowly introduce the scope, so now I can start to release some of the previous hemosiderin yeah, and then you can really realize that the pheromone or monroes start to give way. Yeah, it become from stiff, then they become softer, and you can remove all this debris, which definitely can get into the shunt that can cause blockage. So this is why when we have a repeated shunt malfunction, if the debris is high, so we do lavage that can increase the survival of shunt, in the next time when you do it. So you can see before and after, yeah, and you can see definitely the different before and after lavage. And eventually this child still need shunt, yeah, because of the congenital anomalies, but the shunt survive. We do not need to do any more revision, and he recovered well. So another example, 7-year-old girl, recurrent anaplastic ependymoma. After excision, radiation therapy, chemotherapy, patient come back in reduced consciousness. And you can see the MRI, we suspect there could be a recurrent tumor, yeah? But the ventricle looks okay. So we decided to put an endoscope just to see how we can improve the shunt survival. So now you start to see this again, infective oily material. So using lavage, we start to clearly, clear the CSF, and then slowly we try to get all this effective material from the floor of the ventricle. And as we move along, then we elevate what we call it the slough, then we start to see a tumor. So this also indicate that by doing lavage, you can also make a diagnosis. So this patient actually tumor is seedling along the ventricle. So we can confirm that the tumor has gone everywhere in the ventricle. So we told the parents, looks like the outcome is not good, despite we do revision, but the MRI failed to show that there was metastasis in the ventricle. So this gives you some another information by visual, and you can take a photo, then you can see the tumor is already metastasis. So you can also give a prognosis. So in summary, neuroendoscopy for massive IVH offers safe and more effective surgical treatment compared to EVD in our series. So it allows direct visual manipulation of the clot, effective clot evacuation, allow hemostasis control, hence produce excellent postoperative outcome. So the use of endoscope in our setting is recommended as a management in modality patient with massive IVH with GRAP score more than 6. But again, we have to look at other factors too, patient, age, and the GCS on admission. So that's end my first presentation.